Welcome to Kines 3320, Therapeutic Modalities. The goal for this course is to take your knowledge that you read and watch in the online lectures and turn you into a practicing clinician. So as we are working in this class, I would really like you to focus on trying to apply these skills that you are learning in as many application and laboratory settings as possible. And now an introduction to modalities. Starting with Chapter 3. What are therapeutic modalities? A modality is any device or application that delivers a stress to the body for a therapeutic purpose. Stress is a force that disrupts the normal homeostasis of a system. This could either be negative or positive. Common modalities include cold, heat, light, electricity, manual techniques, and exercise. We sometimes forget that as a clinician, we can be modalities as well. Modalities serve many purposes, but the primary objective of modalities is to create an optimal environment for the tissue healing process, pain relief, improve range of motion, soft tissue mobilization, correcting bony alignment, improving athletic performance, and health-related quality of life, or HRQOL. When we start talking about modalities, I would like you to look at your patients from a problem-solving approach. As an athletic trainer, physical therapist, or other allied healthcare professional, many times our patients do not come in with specific instructions on how to treat them. Fortunately, that is for the clinician to be able to decide. But this also means that there may be more than one right answer. Take, for example, a patient whose chief complaint is chronic hamstring tightness and soreness. How should we approach this patient to decide what to do? There's so many options. Some of you may say that we need to stretch these muscles, maybe with a foam roller, or maybe with an assisted device for stretching. What about strengthening the muscle? Maybe it isn't strong enough for the exercise that the muscle is being subjected to. Or what if this issue is more complex? If we look at the person holistically, we may want to look at their posture. This picture has good posture versus bad posture. The hamstrings may be affected by our posture. If a person's hips roll forward, this could place a strain on the hamstrings. It results in a shortening of the quadriceps muscle, and the hamstrings are then in a constantly stretched position. We may have seen people walking around like this. I typically refer to this as butt out, gut out. If we could work on the posture, we may be able to eliminate this tightness or soreness for the patient. We may choose different treatments, such as stretching the hip flexors and quadriceps, or even performing muscle energy techniques. We will learn about muscle energy a little bit later in this course. But this technique can help to realign the hips and improve posture, which would reduce the hamstring pain. Remember that the body is a kinetic chain, so everything is connected.
Head, shoulders, knees and toes, knees and toes. Head, shoulders, knees and toes, knees and toes. And eyes and ears and mouth and nose. Head, shoulders, knees and toes, knees and toes.
We sometimes have to look at the joint above or below the area that's hurting to be able to effectively treat a person. Sometimes we have to look at their entire body to effectively treat them. When treating patients in the real world, I hope that you treat each patient and injury as unique and therefore make treatment plans specifically for that person in pathology. There is no such thing as cookbook medicine. All injuries and conditions are unique and patients need different things. We also need to consider whether or not we are treating a symptom or treating the cause of the injury or condition. Unfortunately, some conditions we just can't treat. For example, a spinal cord injury. We can do rehabilitation and help the symptoms of the condition, but unfortunately we do not have the power at the current time to be able to treat the cause of the injury and heal the spinal cord. The 7 components of treating a patient are an ongoing process. We need to obtain a medical history, identify the patient's limitations or restrictions, and then identify the underlying impairments. We need to prioritize the issues of the problem. Sometimes our patients come in and multiple areas hurt. So what do we start treating first? What's most important to our patient? We need to set treatment goals, both short and long-term goals. We need to review the evidence. We need to plan the interventions. We need to know the indications and contraindications of the modalities that we're using. We also need to re-examine the patient and assess the outcomes. Page 60, Table 8-3 in the Starkey text outlines and discusses each of these a little bit more. We'll touch on all these pretty much in our lecture as well. In addition to the anatomical issues of the injury or condition, we must also consider the patient's perspective. We need to address the following questions. How is this injury or illness affecting the patient? How do I know what is the best treatment for this patient? Is the patient really getting better? Do I need to keep doing what I've been doing, or do I need to change course and do things differently? So like I've asked you to consider during this course, how could we apply these tools to a real-world application? Let's look at an example of a soccer injury. A player is running down the field and cuts to change directions. She falls and grabs her knee. Uh-oh, an injury has happened. In this case, we're dealing with a 21-year-old female collegiate soccer player with an ACL tear. This mechanism of injury, cutting and planning, is indicative of an ACL tear, so we know that from the mechanism of injury. The athlete has pain, swelling, and loss of range of motion in the knee. She cannot sleep or get comfortable. Due to her injury, she can no longer continue to play soccer. This results in a feeling of isolation from her coaches, teammates, and a possible loss of scholarship. This is her senior year. She wants your advice. She asks you as a clinician if she should redshirt and postpone her graduation, or should she do something else? How would you advise her? How do you know what's right? Having tools to advise our patient can be extremely helpful. The International Classification of Functioning, Disability, and Health, or IFC, is a classification of health and health-related domains. As the functioning and disability of an individual occurs in a context, the IFC also includes a list of environmental factors. The IFC is the World Health Organization, or WHO, framework for measuring health and disability at both an individual and a population level. The IFC is considered as the international standard to describe and measure health and disability. IFC classifies injuries and illnesses as multidimensional. This model is considered a biopsychosocial model, meaning that it considers the biological, individual, and social impacts of a disease, disorder, disability, and its effect on the patient population. We focus on three main areas of concern: impairment, which is the dysfunction of the body's functions and/or structures; activity limitations, which are challenges in performing tasks associated with daily life; and participation restrictions, which are challenges in experiencing life situations. When assessing a patient's progress and level of function, we can use the IFC model. We can first start with the health condition. This is typically a disease or disorder. In our earlier case of the soccer player, this would be an ACL tear. We can then assess the body's functions and structures of the individual. These are considered the impairments. Common impairments associated with ACL injury includes the torn ACL, edema, pain, and loss of range of motion. Impairments are objectively measured, which means that we can quantify them. We can also assess her activity level and her limitations in activity. For this patient, she was having trouble walking, sleeping, and getting comfortable. We can also assess her participation or restriction in activity. She can no longer participate in soccer. The patient's impairments, limitations, and restrictions are considered contextual factors. Contextual factors are affected by the environment and personal factors. Environmental factors include family, teammates, coaches, possible scholarships, graduation dates, as well as many others. Environmental factors are typically external. Personal factors include age and/or gender of the patient, social background, education of the condition and personal knowledge level, past experiences, as well as others. Personal factors are most commonly internal, which means that they're fixed and cannot be changed. Remember that not all of our patients want the same thing. An athlete may want to return to participation. However, an older adult may just want to be able to wash or comb their own hair without shoulder pain. It is also important that we stay positive. Don't focus on the can't-dos of our patients. Rather, focus on the things that the patient wants to do and use the things that they can do to help guide their rehabilitation. So knowing what we do, how do you really know what's best? How do you decide what treatment to apply to each patient if there are multiple options? Evidence-based practice allows us to help determine what is the best treatment for each patient. This is not prescriptive. You have to evaluate different dimensions to determine the proper care for each patient. The purpose of evidence-based practice is to provide the most efficient and effective treatment, thereby maximizing the patient's outcomes and making effective use of the clinician's time. For example, what if we have a patient with wrist pain? You have two choices. Choice 1 is copper bracelets. Reports have indicated that copper bracelets help to soothe arthritis. This is one choice, or maybe you want another option. Joint mobilizations can help relieve signs and symptoms of arthritis. So which treatment do you choose? I would guess that not all of you would necessarily choose the copper bracelets, but some of you might. It isn't necessarily a wrong treatment, but joint mobilization may not necessarily be the right treatment either. If you were confused before, let me see if I can break it down a little bit. Evidence-based medicine incorporates three things: the best available evidence, the patient's values or preferences, and the clinician's expertise or experience. Evidence-based medicine is the same as evidence-based practice, so don't get confused. Evidence-based practice cannot just be one of these three things. It's only when the clinician looks at all three that evidence-based practice occurs. Many people think that evidence-based practice is only using what's in the literature. We must be able to look beyond that to determine the correct course of action for our patients. Unfortunately, sometimes research is old. We must be able to look at the old objectively and compare it with new research objectively to come up with appropriate applications. Most of all research is based off of what we have always done, to see if it works, and if so, why. Usually when someone has a new insight, it's based off of something they've already been doing, which is the clinician's expertise. So how long is research really good for? This depends on the quality and the advances in patient care that have taken place in the time in between. Most of all research, whether there is a significant finding or not, is useful for ruling out or in some type of idea. So it is important, but it isn't the only thing that's important in evidence-based practice. So we also have to discuss what we would consider as valid evidence. First, we'll start with what isn't. These would include magazines, newspapers, anecdotal reports, and anything that comes from a .com. A lot of you like Wikipedia. It is a peer-reviewed source. However, anyone can go in and edit the information, so you can't be 100% certain that what you have found is actually true. Another example is e-medicine, where you can Google symptoms. Sources that do have a good or valid evidence would be professional peer-reviewed journal articles, statement from national and regional organizations or conferences, and anything that has a .org, .edu, or .gov. These websites are highly regulated compared to the .coms. Within evidence-based practice or evidence-based medicine, there are different levels of evidence. As we move towards the top of this pyramid, the higher and more reliable the evidence is. The top tier is considered filtered information. This information has undergone high levels of scrutiny and is less likely to have statistical errors or biases. Towards the bottom of the pyramid, we have unfiltered information. This doesn't necessarily mean that the evidence is not good. It just isn't as high of quality as the evidence at the top of the pyramid. To help us understand, we will explore some different types of evidence. A randomized clinical trial is an experiment or treatment in control group. Essentially, these type of studies are either trying to figure out an answer to a question, yes or no. A narrative review. This type of study is a narrative summary of information on other studies, methods, and results. These studies are essentially figuring out how many yeses or no's that are among the literature. These studies are descriptive rather than statistics. And thus somewhat subjective in nature. A systematic review is an objective literature review that critiques and synthesizes high-quality research. The yeses and nos are now quantified and evaluated for their level of methodology. You may see several studies excluded from the results because there are issues with the way the data was collected. Another example is a meta-analysis. This is an objective study that combines similar research of high quality to demonstrate a statistical conclusion. The yeses and nos are examined with the number of subjects in each study to perform statistics and obtain a conclusion. A systematic review and a meta-analysis are both designed to minimize biases and errors. So again, applying what we've just discussed, how do we use clinical decision-making and the evidence that's out there? We have two methods, Method A and Method B. Method A is proven by a systematic review. It has demonstrated statistically significant improvement of the condition. However, it's extremely expensive. It's a large piece of machinery that a clinic or facility may or may not have. Method B is proven by several clinical trials. It works okay, but is not demonstrated as significant of results. But it has a simple manual technique associated with it. So how do you decide? If you have unlimited funds or access to the equipment in Method A, then that is what we should use. However, it is uncommon to be in this situation all the time. So you may have to settle for Method B, or your other choice is to refer your patient to a place that can help them have the treatment in Method A. It is a difficult call, but we need to make sure that there is a reason for why we are doing what we are doing to patients. This requires critical thinking. You will not treat the same condition the same way every single time, so you need to determine which way is most effective in achieving your goals. What role does the patient play in your decision? And when possible, treat the problem, not just the symptoms. Once we have decided on a treatment, we have to constantly assess whether or not that treatment is working. You need to determine if your patient is really getting better or if they are stagnant in their treatment. There are two ways that we can assess the outcomes of our treatment. Clinician-based outcome measures. These measures are performed by the clinician and are important to the clinician. These are usually objective in measure. We may be trying to assess impairments such as edema or range of motion. Clinician-based outcomes are sometimes referred to as disease-oriented evidence. Patient-based outcome measures are from the patient's perspective and are a little more subjective. These are self-evaluations of activity limitations and participation restrictions. These are important because they allow for a patient and a clinician to determine what the patient values, what is important to them, and why are they trying to get better, and what do they want to be able to do. Patient-based outcomes are sometimes referred to as patient-oriented evidence. Some additional examples of both measures. Examples of clinician-based measures would be a normal range of motion with no edema, normal KT-1000 score, or normal strength. An example of a patient-based measure would be the lower extremity functional scale. This is a little bit larger version of the lower extremity functional scale. This questionnaire asks patients different questions to determine what is important to them and what they are experiencing, such as pain getting in and out of the car or hopping. Patients have to answer each of these questions on a scale from extreme difficulty or unable to perform to no difficulty. Clinical outcome assessments can be generic, such as, does your health right now limit you in these activities? If so, how much? For example, for vigorous activities such as running, lifting heavy objects, participating in strenuous sports, A patient would click either yes, limited a lot, yes, limited a little, or no, not limited at all. Our outcomes can also be disease specific. In cases such as cancer, asthma, arthritis, shoulder instability, and migraine, for example, we may be able to use quality of life scales. An example of this would be an asthma quality of life scale that asks questions that are specific to asthma, such as asthma has interfered with my social life, or I have been limited in going certain places because they are bad for my asthma. They could also be region specific, for example, the DASH, which can assess the arm, shoulder, and hand. They may also be dimensional specific, such as the McGill Pain Questionnaire. This scale asks patients to describe what their pain feels like. For example, is it a pounding, pinching, dull, sore, radiating, or something else? There are 78 words in the English language that are used to describe pain in the McGill Pain Questionnaire. Here's a list of all the words. Some of these descriptions of pain sound absolutely awful, such as beating, lancinating, gnawing, scalding, suffocating, penetrating, and torturing. This table might be helpful for anyone who is still a little confused about the different types of patient-based outcomes. This lists each type of outcome, the definition, example of these outcomes, advantages, and the disadvantages of these outcomes. So again, how do we determine if a patient is really progressing? Are they progressing quickly enough? If they are, how do we know that, and by how much? What is the value we should be at? What is considered normal or standard? What does the patient want or need? And what would you do if they were getting worse? Unfortunately, this is a potential outcome. It is never fun when your patient tells you that they feel worse, but it can happen. At this point as a clinician, you're either going to have to do the same old treatment, or you may need to try something new. To determine progress, we need to have goals. Good goals are SMART. They are specific, measurable, attainable, realistic, and have a time frame. Goals need to be specific. To get better, we may need to increase dorsiflexion in the right ankle, for example. They also need to be objective or measurable. We may want to increase dorsiflexion of the right ankle by 10 degrees. Or we may also want to increase dorsiflexion that allows the patient to climb stairs unassisted. The goals also need to be challenging, but feasible. For example, full recovery or 100% better may not be possible in all cases. And last but not least, we need to consider the proper timeline. When developing goals, we need to consider several stages. What is the final outcome or outcomes that we want? An example of a final outcome may be that the patient will be able to fully return to play by March 6, 2018. This would be 6 months post-operative. We also have to set milestones or long-term goals. Our long-term goals are typically more than 14 days. An example of this would be that the patient will be able to do such and such treatment by February 6, 2018. This would be 5 months post-operative. There are also short-term goals. These are usually set between the time of the injury and the first 2 weeks or 14 days. Our example would be that the patient would be able to do whatever we need, maybe full weight bearing by September 13, 2017, a week from today. Our patients should be involved in the goal setting. If it is not important to them, then most likely it will not be achieved. Chapter 4. Legal Considerations. In addition to treating our patients, we also need to follow the legal rules for our profession. We must comply with the state regulations. These are specific laws that vary from state to state, so you need to know where you are practicing and what you can and cannot do. We must stay within the scope of our practice. This is the legal boundaries that define the manner in which clinicians may practice. For example, can we only administer iontophoresis under a prescription? Can we use it without? Most statutes are very vague. I have provided the State Practice Act for athletic training, physical therapy, occupational therapy, and chiropractic medicine on Blackboard in a folder that's titled State Regulations. I would highly encourage that you look at these for the profession of your choice. For example, in the state of Texas, under the Practice Act for athletic training, physical therapy, and occupational therapy, students may only apply therapeutic modalities under the direct supervision and instruction of an athletic trainer, physical therapist, or occupational therapist. This means that you need to be supervised while delivering treatment to any patient at all times, otherwise you could be violating the state law. There are financial penalties and even possibly jail time for violating state practice acts. In order to treat a patient, you must get informed consent. You need to provide the patient with the following information. You need to describe the modality that you're using, describe how the device works, explain what the benefits are, explain what the expected normal sensation is, so you should know what it feels like before you place it on somebody, adverse sensations to be reported, also potential hazards, and the residual effects. Sometimes when we do a treatment, our patient may be sore later. If they don't know, they may think that something went wrong. Always remember that our patients have the right to refuse. All of these are included in the Starkey text on page 76 in Table 4-2. We also need to make sure that we are protecting our patient's privacy as well. This includes patient confidentiality. The Health Insurance Portability and Accountability Act, or HIPAA, states that all medical records are confidential. Written permission must be granted to release information. A person may be found liable if information is released without consent. Two of the most common issues come from defamation of character. Slander is anything that is spoken. Libel is print or electronic media. This means that you cannot write, speak, or post about a patient's medical condition. If you do, you could be found guilty of defamation of character. HIPAA can be very difficult when you're dealing with minor athletes. Legally, you cannot tell parents anything if an athlete or patient is over the age of 18, unless they have signed a document saying that you can disclose information to specific people. The Family Education Rights and Privacy Act, or FERPA, is a law regarding school records. This includes medical files. This applies to any school that receives federal funds, such as A&M Corpus Christi. There are a few times when health information may be used without the patient's authorization, such as in a police investigation or in a health crisis, such as a meningitis outbreak. If you are unsure, it is better not to release a patient's information and consult with a lawyer. Professional negligence. This can occur if an individual provides substandard care or acts outside the professional norms or acts out of carelessness. There are 4 things that have to be proven in order to be found negligent. If any one of the 4 is not proven or is not there, then the person is not guilty. Number 1, the person has to have a duty to act. For example, a physical therapist being paid by a patient or their insurance is a contract to act and treat the patient. First, we have to determine if there was a duty to act. If there was, then we next have to determine if there was a breach of that duty. For example, did you have the duty to perform CPR on a patient, but you used your foot instead of arms or hands for chest compressions? That would be inappropriate. If we had a duty to act and we breached that duty, then we move on to the 3rd phase. Did the patient suffer harm? Remember that harm can be in many different forms. They could include physical, emotional, psychological, financial, quality of life, or many other forms of harm. If this has happened, as well as the first 2, then we need to find out if the negligence caused the harm. There has to be a causal connection between your actions and the final outcome. If the negligence did cause harm, then we have a guilty verdict. If we answer no to any one of these 4 items, then the person is not guilty. There are some definitions that you also need to know. Different types of negligence can be defined as well. Malfeasance is providing the wrong care. Misfeasance is providing the right care wrong. For example, commission. You did something that you were supposed to do but did not perform it at a level that is expected of you. Nonfeasance, you did not provide care but you should have. An example of this is omission. Omission is when you did not do something that you should have done when a response is necessary from you. Malpractice is negligence on the part of the professional serving in the line of duty. One of the ways to minimize the risk of liability is to make sure that all of our modality equipment is taken care of. We must calibrate the equipment. Calibration makes sure that the output listed on the machine is actually occurring and the machine is functioning properly. Modality machines must be calibrated often, usually either annually or biannually, meaning every 2 years. This ensures safe treatment of our patients. We cannot afford to be sued. We also need to make sure that we are reading the operational definitions and manufacturer's warranty to identify the manufacturer's standard. Another way to minimize our risk of being found guilty is to document everything. If you do not document and write it down, for all legal purposes, it never happened. So remember that you do not just treat one person every day. And if you didn't write things down, can you really remember what you did, how you did it, or if it was effective for the next treatment? Why do we do this? To document treatments that you did or are doing, to show the patients their progress, to show insurance companies that you are worth paying, to protect yourself from claims of negligence in court of law, and also research is based off our medical documentation. What treatments did you do? What was their range of motion, strength, function? Be sure to include specific settings or directions for each treatment so that if you are gone, someone else could read your report and deliver the same treatment. This ensures a quality of care every time and a continuity of care. When do we document? As soon as possible. You need to document what you did as soon as you are done doing it so you do not forget. Also, programs have dates on them that you cannot change, so it can be hard to explain how you know what you did 3 weeks ago if you didn't log it and have been going off memory. This is not a strong defense in a court of law. Where do we document? In a secured location. We need to be physically secure, maybe in a database or a filing cabinet. Some common types of documentation include SOAP notes, progress notes, short and long-term goals, doctor's notes, and discharge notes. We must have established and built a case for the patient's readiness to be on their own. SOAP notes are one of the most common documentation method. SOAP notes stand for subjective, objective, assessment, and plan. Subjective is what the patient told you. Objective is what you found in your evaluation. Assessment is your diagnosis of the injury. And the plan is your plan of attack for addressing the goals. Remember, it isn't just lawyers who may be interested in your documentation. Insurance companies may review your documentation to determine if reimbursement for services is warranted. You may not get paid for treatment you provided if you do not have good documentation. The other thing documentation allows us to do is to protect ourselves and maintain our professionalism. If the patient is uncomfortable with us or around us, it will be very hard for them to want to come and get treatment. If we have wronged somebody, we should refer the patient back to another therapist or clinician and step back professionally and be understanding. Ask the patient if they're comfortable. We must use discretion when to treat or when to refer. Always communicate thoroughly and be accountable. Don't joke around about treatments, and the patient's comfort is our #1 priority. Real quickly, as a wrap-up, I just wanted to remind you of some really important things from this lecture. Modalities are not a miracle cure. We can only do what to the healing process? Is it optimize, facilitate, speed up, or skip? That's right, we can either optimize or facilitate the healing process. The healing process is necessary for recovery, so we cannot speed it up or skip it. Therapeutic modalities are not meant to replace therapeutic rehabilitation, but rather enhance the rehabilitative process. Individuals will heal with or without the use of modalities. Modality usage aids in the facilitation of the healing process. This is really important. Quiz number 1. It's going to be available via Blackboard under Contents in Module 1. It's over Chapter 3 and 4. It's worth 10 points, and you will have 10 minutes to complete the quiz. It is open note and open book, but you cannot communicate with others during the quiz. The quiz will consist of multiple choice answers, short answers, and fill in the blank. Since your quiz is on Blackboard, please make sure that you have a reliable internet connection during your time. Same thing goes for the exams.